So let us have our case one without wasting much of our time. She is a 28 years old female, G6, gravidas 6, para 2, live 0, abortion 3. She presented to us in the emergency room with the pain abdomen at 19 weeks of amenorrhea. Her pregnancy records up till now was uneventful. Her routine blood tests were normal. She did not undergo any NT scan, and she had done her 16 weeks scan, that was normal. She was tested by triple test for Down syndrome, which was low risk. Her obstetric career, first pregnancy 10 weeks missed abortion, second pregnancy 26 weeks IUD, third pregnancy 14 weeks missed abortion. There were not much data of the first three pregnancy. Fourth pregnancy, 30 weeks, she had an IUD. At that time, there was a very high BP and she complained of headache and loss of fetal movement. Fifth pregnancy, she had 8 weeks missed abortion. Currently, she is 18 weeks and IUD. There is no relevant family history except that her father died of heart attack at the age of 48 years old. She never had any ANC checkup as she was a domestic helper living at a village. So in this pregnancy, on admission, her significant examination findings were BP with 136/86 and bilateral pedal edema was present. So this is a question for our first panelist, Dr. Snehal. What do you think, how is the recurrent pregnancy loss defined and what is its frequency? Is there a consensus definition? And kindly enlist the most frequent causes of RPL.
So recurrent pregnancy loss, if we go and search many publications, many guidelines, like how do we define recurrent pregnancy loss? There are many definitions, but if we consider ESHRE, it says that 2 or more pregnancy losses, we can term it as recurrent pregnancy loss. But yes, RCOG says 3 or more pregnancy losses is considered as recurrent pregnancy loss. Again, WHO also says that 3 or more consecutive pregnancy losses is recurrent pregnancy loss. But I think we all agree that each and every pregnancy is very important in today's life where we are working. So I think let us go with 2 or more recurrent pregnancy losses, 2 or more pregnancy losses. Then incidence, if we go as the incidence of recurrent pregnancy loss, it is at least 1 in 300 pregnancies. And if we go incidence wise, it is 2% is the incidence of RPL. As here, I think,
as the pregnancy, with first pregnancy, the incidence is like just 11%. With each successive pregnancies, the percentage increases.
True.
So the etiological factors?
So the etiological factors of recurrent pregnancy loss, if we consider, I think when we go through the papers that ASRM has published a very nice study, they have taken around 1,398 patients. They have evaluated each and every patient according to their evaluation guidelines. And they found that around almost 55% of patients were having unexplained recurrent pregnancy loss. But yes, each and every patient should have an answer that why she is undergoing recurrent pregnancy loss. So we need to evaluate each and every patient for RPL. So let us see what are the causes of RPL first. It can be a genetic factor. It can be anatomical factors like uterine anomalies. Then thrombophilias, most of the times it is not hereditary but acquired thrombophilias if we go for like APLA syndrome. Then endocrine factors like diabetes mellitus, thyroid disorders, and in some cases you can say that hyperprolactinemia may cause RPL, but it has not been proven yet. Again, when we go for the evaluation per se, we also should pay attention towards the chromosomal analysis. When we are looking after the products of conception, when she is having again the third pregnancy loss or after second pregnancy loss as well, we should send the products for chromosomal microarray analysis. Right now we were sending for G-banding technique, chromosomal pattern, but yes, it's been said that there is
Snail,
will go into any details. You just need to enumerate the test you want to do.
Okay.
Because there are bigger cases later on.
Okay, ma'am. While evaluation of this case, we should, as the case history says, it is most we should go for APLA testing first because she is having 1 pregnancy loss, that is 1 IUD also, that is of 30 weeks. So we should go for APLA testing as the criteria says. Then genetic testing, yes, POC should be sent for genetic testing. Anatomical reasons, we should better go for 3D ultrasound as the sensitivity is almost 97.6%. Endocrine testing, thyroid antibodies, and TSH should be done, prolactin, and glycosylated hemoglobin should be done. Regarding history, extremities of weight, alcohol, smoking should be considered. Counseling should be done. Regarding this patient, I think most probably the cause might be apella. And yes, during her workup wise, she has not done her NT scan, her double marker was not done. And regarding anomaly scan also, she should undergo anomaly scan. And we should send her POCs for examination.
Actually, this case, looking at the obstetric history, as you rightly said, it is pointing more towards APLA. So now let's see what happened with our case. She was due to missed abortion at 18 weeks. She was admitted for induction, and while the process of induction, her BP shoot up, her blood parameters went deranged. She was given Maxilf. Thankfully, smoothly she delivered, and after delivery, her BP came down to 133/81. 6 weeks after the delivery, as advised by us, she came and she was advised APLA, and she turned out to be APLA positive. So my question is now for Dr. Parikshit. What are the different tests available for thrombophilia screening? What are the treatment modalities available for thrombophilic disorders? How do you monitor them? How should we monitor them during pregnancy? Will you continue anticoagulant postpartum? And what should be the plan of management for future pregnancy? So let's take one question one by one. So Dr. Parikshit?
Yes. So first is what are the tests for thrombophilia screening? So amongst thrombophilia, it could be, either inherited or genetic thrombophilia and then acquired causes. So amongst inherited or genetic thrombophilia, you can do factor V Leiden mutation, hyperhomocysteine mutation, prothrombin mutation, protein C/S deficiency. Apart from that, MTHFR also. But then genetic are not related
That's
with, have not been correlated with recurrent pregnancy losses. Most common is inherited thrombophilia, and that is antiphospholipid syndrome. So in that, we should test for, there are 3 standard antibodies or tests which are available. That is, first is lupus anticoagulant. It is a functional assay. Then there is anticardiolipin antibody, IgG and IgM. And third is anti-beta 2 GP1 antibody, IgG and IgM. So these are the 3 standard tests that you need to do for patients with recurrent pregnancy losses where APL is suspected. Then I think second
as you rightly said, even the guidelines says that we should not be often screening for hereditary, but yes, they are proven, these acquired ones are proven. For the second question, the management per se.
I think second question was management.
Yes.
So once the patient is proven that patient has antiphospholipid antibodies, so amongst that LAC and ACLA are more correlated with recurrent pregnancy losses. And the standard of treatment is low molecular weight heparin plus low dose aspirin. That is around 75 to 100 milligram of aspirin plus low molecular weight heparin. That is the standard for patients who have antiphospholipid syndrome and recurrent pregnancy losses.
My question here was, we have been talking recently in the past regarding severe preeclampsia and all. We have raised the ecosprin value from low dose like 75 to 150. So for the Indian general population, should we take, with the BMIs of the mother we are having, should we take 75 or 150? What does the Rheumatology Association talk about this?
We have, the literature is, it comes from mostly like from Western literature only.
Yes.
So that is still 7500. I think that depends on case based. Like if you feel that it has not worked or patient is pretty obese, then going up to 150 is okay. But the literature is 100, 75 to 100 milligram.
So once we started in pregnancy, we don't get an idea how to monitor. So what are the tests we should do in pregnancy?
There is no requirement. If patient is on low molecular weight heparin and low dose aspirin, there is no need to monitor as such for if the patient is planning for pregnancy. So with low molecular weight heparin and low dose aspirin, it is not recommended as such to monitor.
Yeah, because antenatally during pregnancy, even the APTT goes high. So please talk a word about seronegative antiphospholipid syndrome. What is this entity?
Yes. So seronegative is a very controversial topic in rheumatology, and we have seronegative of everything. We have seronegative rheumatoid arthritis, we got seronegative SLE, and there is this concept of seronegative antiphospholipid syndrome. And in rheumatology, you need to know whatever antibodies are there. I mean, they are not 100%. It's not you can't separate it like milk and water. So we have to take it with a pinch of salt. These are the antibodies which are commercially available. There are n number of antibodies which are present in antiphospholipid syndrome, which are directed to the phosphatidylserine or the other phospholipids. But the problem is they are not commercially available. So if you have a patient who has suspected
History.
recurrent pregnancy losses, suspected APS or behaves like APS, so then we can always label them as APS and treat them rather than just saying that this is not APS. So it is not true. If clinically it seems like APS, then we can always treat it like APS. And of course, there's this test. I think many people also get it done, like antiphospholipid antibody IgG IgM. So that is not a standard test for antiphospholipid syndrome, but it tests for other phosphatides. So like phosphatidylserine, phosphatidylethanolamine. So many times that can be positive. So I mean, and there are other also antibodies, but that are not commercially
Okay.
available. So you can treat it like a APS.
So once in pregnancy, since we have started the prophylactic doses of it because her antibody titers were positive, so your advice regarding postpartum, should we be giving it, and if given, how long?
Yes. Anyways, I mean, with pregnant patients have a hypercoagulable state, and patients who have antiphospholipid syndrome, they are more likely to get a thrombotic event. And after delivery, also they are in bed rest or not moving. So there is more chances of thrombosis. So one, you have to give in postpartum period. Second, till what duration? It depends on two factors. One is whether she's just obstetric APS. If she's just obstetric APS, you can give it till 6 weeks. The agent is either you can go with low molecular weight heparin or warfarin once
unfractionated.
patient is able to sort of tolerate. The other thing is patient, if she had any event of thrombosis prior, so she had a thrombosis arterial or venous, and she is now obstetric APS as well. So there you need to continue low molecular weight heparin for 6 weeks, and then you have to maintain that, then switch to warfarin and then maintain the INR for whatever event she had prior to that.
Fine. So Dr. Snehal, what would we advise this lady for her future pregnancies?
Future pregnancy, she should be coming earlier. As soon as her pregnancy test is positive, she should visit her gynecologist.
When should we
Then-
start heparin and when should we start ecosprin?
Now there is again a controversy. Most of the times when if we search a lot, then they say that as soon as the pregnancy is detected, you should start her on aspirin and low molecular weight heparin, as the infertility specialists do. That is an IVF.
So we
like
should
in
wait for
IVF.
cardiac activity.
Yeah, but we should wait for cardiac activity, as the consensus says. We should wait for cardiac activity. Then, as the high-risk pregnancy goes on, like we should have a double marker NT scan should be done at 11 to 14 weeks of gestation. We can go for early anomaly scan at 16 weeks of gestation, 20 weeks we should go for anomaly scan, 24 weeks 2D echo and regular ANC follow-up. We can increase the ANC visits as well.
Okay. Thank you, Dr. Parikshat, and thank you, Dr. Snehal. Dr. Soumitra, ma'am, I would ask you if you have any other expert opinion over this case or anything would you like to add in that?
I think if you see per se the definitions of RPL, I just wanted to point out one thing, that because there are the guidelines, that is ASHA guidelines, unless they have not included the ectopic pregnancy and the molar pregnancy. That is one. And secondly, SRM guideline, they have mentioned that there should be strong positive evidence of the pregnancy. That is ultrasound or clinical
Histopath.
pregnancy. That is to define the 2 to 3 consecutive, that's okay.
Biochemical not included.
Biochemical. And if you evaluate per se as a case of RPL, then we don't have to jump directly for the immunological and genetic studies. We should start from the basics. And secondly, first important point is for the lifestyle modification. That should be evaluated, and then cavity evaluation, sonography and 3D evaluation, and then you go forward for the APA, that is antiphospholipid syndrome, and then endocrines. Then if there is evidence or history is there for any stillbirth or recurrent pregnancy loss or IUD or any thrombotic event, then you go in for this thing, that is chromosomal aberrations are there in the products of conception. They then do parental this thing, counseling and later on. Thank you.
Thank you, madam, and thank you, our panelists. Now we'll move on to our next case. That will be by Dr. Darshana, madam.
First question is for Dr. Shilpa. 32-year-old doctor couple came to us with the investigations done and no cause was found. She's a case of unexplained RPL. Now, how are you going to manage this case? She has all the tests done, so we won't repeat the tests. Okay. You imagine you have everything in front of you. Now what?
Okay. Doctor couple done every investigation. So we have to reassure the couple that you will conceive. They are already in frustration, depression, ki everything is come out to be normal. Now what? Because next is all immunological test which has to be done, because this falls in idiopathic recurrent pregnancy loss. And now the all experiments, all journals are stating same thing, ki there is some immunology behind the pregnancy, even RPL and RIF both, because fetus they consider as a graft. So it is rejected. And when it is, we are considering fetus as a graft, then we have to move to the immunological test. Some tests which are available are natural killer cells, both from peripheral blood and uterine blood, then CD4 and CD8 ratio, anti-HLA and anti-HY antibodies, then anti-sperm antibodies, and also the sperm DNA fragmentation we should test, because generally, routinely, we don't observe semen analysis, sperm DNA fragmentation. This is more commonly seen in idiopathic RPL patient. Then again, there are variety of investigation which can be offered according to the when you explain you have to explain why you are doing so many tests, because these are all rarely done tests.
So the tests were done that you have advised, and now her NK cells were positive. So she came to somebody who believes in LIT, which is lymphocyte immunization therapy. She conceived spontaneously and had a successful outcome. Now to Dr. Mugdha Raut, who is an expert at LIT. Dr. Mugdha, what do you feel? Now I have sent her to you. I believe in LIT. I want you to counsel the patient as to the role of immunological factors. I want you to explain to me as well. And what are you going to do about her?
So, rightly, like Dr. Shilpa said, that there is a role of immunological factors in the fact that the fetus is treated as the fetus is an allograft, is a semi-allograft, receiving 50% of the paternal genes from a totally unrelated father. So ideally, according to the graft rejection principle, the fetus has to be rejected. But our body gives a special status for the fetus, which is known as the paradox of pregnancy, or you can call it nature's miracle. So where the fetus is, as soon as the pregnancy enters the uterus, there are certain asymmetric protective antibodies which are formed around the uterus, which prevent the attack by the immune system and prevent complement activation, and hence they protect the pregnancy. At the same time, certain cytokines which are released because of the HCG hormone, the progesterone, the PIBF, and the T regulatory cells. The T regulatory cells have now emerged as the central players. T regulatory cells are basically immunosuppressive cells. They are present in our body when there is they come into the body when a lot of infection is there, or after the infection is cleared by the body, to suppress the immune system can now stop. So these T regulatory cells are the natural T regulatory cells which come into the uterus and cause local immunosuppression, and that is how a pregnancy grows naturally to term. Now, in certain patients, this happens in 90%, but in 10% of the patients, this immune protection does not happen. The reason is still under research. So we don't know what is the reason why this protection is not happening in certain pregnancies. And that is where lymphocyte immunization therapy comes in the picture. We do the test like HLA cross match. Now the HLA cross match basically tells us whether these asymmetric antibodies are being formed in the mother's body or no. Then the next is the natural killer cells, where there are raised CD3 cells. CD3 cells are basically required for immune attack. And CD16 plus 56 balance these CD3 cells. You can consider it like a weighing scale where it equalizes and it prevents the CD3 cells from coming in contact with the pregnancy. Another one is serum TNF alpha, which is basically a inflammatory cytokine, which we commonly call it as TH1. So this is very important. It is required by our immune system to protect our body against infection. But when it just keeps, after infection goes, the level has to come down to 4 to 12 nanograms. But when the level just keeps high, either there is some infection in the body, or second is the TNF alpha is just present and it goes and attacks the oocyte.
Fetus.
It prevents the second, the second meiotic division gets affected, and therefore the oocyte quality is affected. So ultimately there could be even an abnormal embryo which is being formed. And then it is going to affect implantation. TNF alpha attacks at every stage, from implantation right up to maybe even late IUFDs. Like we have seen IUFDs at even 7 and 8 months, recurrent IUFDs with all reports normal and all other so-called possible immunomodulatory treatments given, where only LIT has shown the difference. So TNF alpha is something which we really take it very seriously, and if it is high, yes, we do treat it. LIT is one of the treatments along with certain passive immunomodulatory treatments. The endometrial NK cells also are not supposed to be present in the uterus. They are the end stage cells which are a conversion of CD56 to CD57, and these are highly toxic cells, and with the help of perforin and granzymes, they are going to attack the fetus. So the presence of endometrial CD57 cells definitely indicates that there is an alloimmune problem and it has to be treated, and LIT will work. The TH1, TH2 cytokine ratio is basically still not available in our country. TH1 is TNF alpha, TH2 are the interleukins, IL4, IL6 and IL10. So abroad they do the ratio before, after treatment also. Even the Treg cell estimation is still not available in India. There are certain labs, they say they are doing it, but we don't have any specific idea as to what is the value for the Indian population. So it's still under trial, and abroad they definitely do T regulatory cells before any alloimmune treatment and after the treatment.
So these are the guidelines by the various bodies. So
So of course, as of now, there is no definite evidence that LIT works.
Yeah.
So, but I mean, I have seen it works wonders.
Yeah, see, I mean, guidelines, all which are put up are basically, they were put up much earlier. And there are a lot of recent papers coming up which are definitely showing the effect of LIT. And there are papers from Brazil which are coming up. Our own paper has gone from India, which will be now published in the American Society. Our book has come up, which has showed our clinical data. China, Japan has come up with their own data, which has definitely shown how lymphocyte immunization therapy is beneficial. So I think, yeah, it is something which we have to really look at in unexplained, because according to the first slide where ASRM says that 57% of the cases were unexplained, then we have to look at a practical solution. We can't, a patient is sitting in front of us.
We
and
can't deny the patient treatment. If it is working, then we should offer. If the patient is affordable, we should offer.
Only thing is with LIT, we should be telling the patient that it is still early in its conception, and it really won't harm you. There's no harm in trying it. Any other adjuvants along with LIT, Dr. Mugdha?
Yeah, definitely we recommend. As we had said, one, vitamin D3 supplementation is a must. Uh, we cannot test the MTFHR gene in all the patients, so we advise L-methyl folate. Uh, Intralipids. Now, intralipids are definitely a cheaper alternative to IVIG. Intralipids are known to reduce the level of the natural killer cells. So when a patient's CD3 percentage is very high, they are the ones after LIT will definitely benefit with intralipids. We don't use immunoglobulins because of the risk factors of IVIG, but we recommend intramuscular immunoglobulins every 15 days to 3 weeks. Then we definitely recommend dydrogesterone up to 24 weeks of pregnancy. Because at 24 weeks of, at 18 to 20 weeks, there is a second wave of placentation. And at that time, the NK cell attack can be extremely detrimental to the fetus. So dydrogesterone additionally helps in reducing the NK cell levels. Abroad, they repeat doses of LIT till 6 months of pregnancy. But we don't do it because of the cost factors in our country. Like in UK, one sitting costs £3,000, but people afford it. So they continue that. But here we use other alternatives. So intralipids is a good thing, dydrogesterone is a good thing, and natural micronized progesterone in the dose of 400 milligrams twice a day, orally or intravaginally, but that also up to 24 weeks. Now, we also recommend ecosprin, this aspirin in the dose of 150 milligrams. And we don't go for the BMI or anything, we just recommend at 150. And low molecular weight heparin, 40 milligrams. Because heparin is required for implantation also. And to create a strong bond between the uterus and the embryo, heparin is required. There are a lot of interleukins and cytokines which are released with the help of heparin. So heparin is definitely required, and we also recommend strongly glucocorticoids. So they really play a role in, because these patients who have RPL, have their endometrium is shown to have poor levels of steroids, basically glucocorticoids. So there we definitely recommend Vizolone in the dose of 10 milligrams 3 times a day for up to 12 weeks. And we've done close to 1,500 cases. We've not had a single side effect related to Vizolone. Yes, we have to keep a watch on the sugar of the patient, because, especially in case of polycystic ovaries. And next is what we recommend in patients who have a raised TNF-alpha is hydroxychloroquine in the dose of 400 milligrams right up to 9 months.
Any
One of the
serious
worries
side
with,
effects?
sorry?
Serious side
No,
effects?
that's what. One of the worries with steroids would be AVM. And a lot of my doctor patients do ask this,
Yeah.
aren't you worried about AVM? Avascular necrosis.
Yeah, but in the dose of 30 milligrams only for 12 weeks, we know where people have used even 60 and 80 milligrams steroids and causing AVM. But whatever dose we have used till now, and we have a full follow-up of those patients, we've still not had a single case where AVM has been seen.
So should we stop after 12 weeks or do you
Yes.
taper the dose?
We taper the dose to 1 BD, means 20 milligrams, and then gradually taper it as per steroids have to be tapered. So by about 14 to 16 weeks, the steroids are stopped.
Thank you so much for that, Dr. Mugdha. Dr. Samitra, any comment on this case, please?
I think very difficult to comment upon, because as such this immunological cause is very rare. And if you see all the international guidelines, they do not even recommend for the immunological test. And the therapy also, they do not recommend unless there is a primary immunological disease is there. But this is the area of definitely concern of research also. Further research is definitely required. And if you are valuing the patient, see the value, what they want, exactly they want, they're interested in the pregnancy. So we need to counsel the patient about the therapy, about the immunological causes.
So in fact, this is typically where it's research versus clinician.
Yes.
And I think it's the patient who
Area
wins
of
in the end.
research interest.
Yes,
Definitely,
absolutely.
we have to do something for the patient.
Absolutely. Thank you so much.
So our next case, we'll move on. She's a 31-year-old lady with P2 and life 0. She's married life 8 years and she has a non-consanguineous marriage. So obstetric history, her first was a normal delivery, girl child, but unfortunately the child expired at the age of 18 months due to some uncontrolled scissors. There was no workup done at that time. In the second pregnancy, again, she delivered a normal girl child, and this time again, the baby had the same fate at the 10 months of age. But this time, the specimen was evaluated for some genetic testing, and there was some variation seen. So this question is for our panelist, Dr. Girish sir. What is the probable etiology, and how will you counsel this patient?
Yeah. So, as per the history, the first baby died at the age of, after age of 1.5 years,
months.
something like that,
Yes.
with the seizures. So probably, and the patient was not evaluated. So the cause may be either any cause can be there. Even the febrile illness can be there also.
Yes.
But when second time the baby was evaluated and some transition was found, it means the cause was something which is, related to the chromosomal anomalies. And that's why in such cases, just to get the hint, the parent should be forced for this karyotyping or microarray. I mean, the genetic study of the parent should be done in this case, I think.
So here the parental karyotyping was done, and in fact parental CMA was done, and the couple had the same genetic variation, which I'll be showing you the results. The couple was advised IVF. Now, will you advise genetic testing of the product of conception? Like here, though we had the history, they had advised. There are miscarriages also in those product of conception. Will you advise genetic testing? And if, what sort of genetic testing?
Yes, genetic testing should be done in this case, and usually nowadays we are preferring microarray instead of karyotyping, because there are some advantages of microarray rather than to karyotyping. For example, the karyotyping, it needs a live tissue for the culture. Then the culture failure are very common in the karyotyping. Then they take little bit more timings. Then the gestational age should be more in karyotyping, whether as compared to in microarray we can get the results even with the 6 weeks of gestation.
Yes.
Yeah, microarray are little bit costlier than the karyotyping, but they are cost benefited, and we can come to a certain conclusions. So microarray should be done in this case.
Yeah, even the important guidelines are quoting now microarray as the first test for the genetic testing. So my next question will be, how should we collect the sample, how should we preserve it, and in how much time we should be sending back to the genetic lab?
Yeah, the first and most important thing, many practitioners, they are sending the whole fetus for the genetic testing, which should not be done. Actually, one should take the placental tissue, it should have at least 50 milligram of the placental tissue, or more than 1 cubic centimeter. Then if umbilical cord we are getting, then it should be more than 1 centimeter. And if at all we are sending the blood sample of parents for this karyotyping, the blood should be sent in the EDTA tube, and it should be preserved in the either ringer lactate or the normal saline solution.
Many times we do a mistake. We put it in the formalin. We think it has to be
That is
sent
very
for.
wrong. Actually,
and that sample is destroyed. So the baby CMA test was done, and the parent CMA test was done. Here, if you will see the report, the baby had the same chromosomal aberration which the father and the mother both had the heterozygous, and unfortunately both the time the baby had the same thing. So they were advised IVF, and they opted for IVF actually, and they went. Now in this, how will you interpret this genetic report, and what further advice would you give her according to the report? If euploid, then what advice? If aneuploid, then what advice?
Yeah.
Would you advise parental karyotyping? And how will you counsel to a couple with unbalanced translocation or inversion?
Yeah, in this case, actually, the report is very obvious that both the parents, they are having some problem. So in this case, the IVF with the donate gamete is more preferable. But in another cases, if the POCs, they are aneuploid, then the other further investigation should be done. What are the causes for this recurrent this losses? Then if the POC, they are euploid, then instead of going for the further investigation, directly the IVF can be suggested. And if at all there are no problems observed, then the test, the other this investigation should be done to achieve the thrombophilia or the sperm DNA testing, then luteal phase deficiency. The other things we can look forward.
Yeah. Actually, parental karyotyping gives you a very narrow approach. Only the karyotyping they come up with the 23 chromosome. But when we do the microarray at the nucleotide level, they give us the aberration. What is it?
Correct.
So next question is for Dr. Mugdha. What is PGD and PGS?
PGD means pre-implantation genetic diagnosis or pre-implantation genetic screening. Nowadays, we prefer PGTA, pre-implantation genetic testing for aneuploidy. When a patient come to us with recurrent pregnancy losses or recurrent failure, we ask genetic testing like microarray, karyotyping, but we also ask the many times we just screening for the female partner, female partner, female partner. We forget about the male partner. We don't bother about DNA fragmentation index. If more than 30% DNA fragmentation index in male partner, then sperm DNA fragmentation, RPL is there. Then another thing is microdeletion. Many times patient come with a severe oligospermia patient, but conceived prior, naturally conceived and pregnancy loss is there. So डॉक्टर से इक्सी के लिए क्या एक स्पर्म लगता है कुछ नहीं इक्सी कर लेंगे बट नो डू माइक्रो डिलीशन वाई क्रोमोसोम माइक्रो डिलीशन इफ वाई क्रोमोसोम माइक्रो डिलीशन इज देयर इन दैट केस प्लीज डोंट आस्क फॉर इक्सी विथ हस्बैंड स्पर्म completely counsel that patient to go for donor sperm because microdeletion gives pregnancy, give live birth. But if there is a male child, 100% infertility in that male child. First thing. Second thing, some researches are going on there. If microdeletion is there, then there are many cases, there are percentage of in offsprings having cancer. So please don't forget about male partners DNA fragmentation index and microdeletion, one thing. Then if you sorted the female partner counseling and male partner counseling done, then microdeletion done, DNA fragmentation index, you have all reports in front of you, go through that reports, then what is PGD and PGS? Why we need that PGD and PGS? If there is a pregnancy loss and we know there is a problem in parents, but many times they want their own child, their own biological child, don't want their donor cycle. So at that time, please ask, okay, because we know that chart, 50% female, 50%, then 20, 20. So ask for PGD-TA for aneuploidy, and if report comes to you after PGTA, and you in that if you send 4 embryos for PGTA and 2 embryos with aneuploidy and 2 with euploidy, then transfer single embryo transfer and wait for the result. Okay. And it is a very beautiful test, PG, but in India, patient cannot afford the PGT or PGTA.
So we have labs here at Nagpur where they are testing it.
2 types of PGD tests are there. Pre-implantation genetic diagnosis or screening or test aneuploidy. Invasive and non-invasive.
Yes.
Again, non-invasive, we biopsied the trophoectoderm. For previously, day 3 embryos, we biopsy 1 blastomere and send to the genetic lab for screening. Okay. Nowadays, day 5 blastocyst, trophoectoderm, we biopsy that and send to the genetic lab. But nowadays, non-invasive method is also there. They asked you to culture the embryo till day 6 or hatching stage. Many times, day 5, late day 5 stage, embryo hatched and few cells naturally drop in the media, culture media, and you just freeze the embryo and that culture media with hatched cells, you collect that media and send to the lab. But again, it is research going on all these things. So, go to invasive PGS screening, PGTA, and
Yeah, that continuing that line of non-invasive, there is one more future test coming up, that is maternal cell-free DNA. It is not only being used for Downs, but also they can be used for these genetic testing. So the take-home message for this case is when to consider testing, if there are multiple miscarriages, if there is a familial history of congenital abnormality, if there is a previous pregnancy with chromosomal abnormality, fetal structure abnormality on ultrasound, yeah, chromosomal balance translocation in a parent, or a stillbirth. So now, sir wants to
Yeah,
speak.
I want to put one point. Ma'am, actually, I have gone through many patients that the patient having only one this miscarriages, many gynecologists and obstetrician, they are rampantly advising the karyotyping of the parents. So everybody should be very serious about this and the proper decision and you should be able to diagnose the patient in a very proper way with the proper history, then the clinical examination, and even the economy and the economical burden to the patient should be also considered in your day-to-day practice. So every time, there is one term called as RPL something
Panel.
RPL panel, and every patient is being forced for that even after having only one miscarriage. So anticipation is the most important thing by the clinician, because the patient is already traumatized, not only economically but even psychologically also.
Yeah.
So all these considerations should be there, and the smartness of the clinician is the first criteria for the diagnosis and management of the
In fact,
RPL.
that was the whole point of this RPL panel, that we should have had more people so that, a good
convey.
take-home message is conveyed, but unfortunate. Anyway, let's
One
carry
more
on.
thing. Recently, we faced one patient with PGTA, 6 abortions, and we got only 2 embryos. We sent that embryos for PGTA, and both embryos aneuploid. So we refused to transfer the embryo, but husband is still insisting do the embryo transfer, because the Google is the master
The god.
of nowadays. नहीं वो तो अंदर जाके कुछ ना कुछ हो जाता है, और कभी कभी ऐसा होता है कि हो जाएगा. We refuse that, and again we ask him to go for IVF if you want, but don't do the embryo transfer with these embryos. And luckily, that patient again after 3 months conceived, and luckily she delivered a male child, a male baby now. But I don't know, वहाँ के डॉक्टर ने उनका वो baby boy, and that patient all trisomy in men.
Actually, aneuploidies have a tendency, as the number of pregnancy
Yes.
increases, they get corrected.
They get corrected.
So maybe that would have been
That's
a case
why
in this
that
case.
patient asking
Yeah,
us.
they would have also Googled the same thing, and hence I guess. They. So let's move on. For our expert, I would like, Madam, would you like to add
I
anything
agree
else?
for that, because these cases we, as per guidelines, don't do always all these tests for the genetic studies. As Dr. Mani has said, we should start from the RPL, and if it is indicated, then go in for all the genetic investigations. And definitely there is a strong role of counseling to the patient if you are doing this PGS and PGD. So we should be doing counseling. Has got a lot of
Yes.
it
This
is
is not
difficult
for
also
all patients.
to counsel the patient.
Yes.
Definitely.
If there is a report of karyotyping or a microarray report with the parental microarray report, then only we ask patients
Yes.
for PGD or PGS. Not for every
patient.
Not for every patient.
And it is not mandatory on the part of every obstetrician that
Yes,
they should know
yes.
everything about this microarray and
Yes,
karyotyping. They can
exactly.
take help of geneticists also. So the proper counseling and proper
Should be
decision.
at that level, multidisciplinary.
Yes, and
multiple
proper
approach.
referral and help of a proper person. It everything matters.
In fact, to be medico-legally safe, there should be a geneticist involved in any of these kind of cases. Shall we move to the next case? Case number 4, please. So this is for Dr. Himanshu. We have a 36-year-old lady. She's had 2 miscarriages and comes to us with a recent pregnancy loss. Her last miscarriage was 2 months back, and she's resumed her cycles. Both her miscarriages were at 6 and 8 weeks. She was managed medically. Her cycles were regular. All her RPL panel was normal. Serum TSH was 5.6, prolactin was 39 nanograms per ml. Fasting blood sugar was found to be 130 milligrams, and HbA1c was 7. So, and she was obese at 12.
Can we just go to the previous slide, please?
Yeah, sure.
So basically, I would like everyone to focus on the last 3 lines. So all her RPL panel is normal.
Except.
Yeah, all the other RPL panel is normal. TSH is 5.6, serum prolactin is 39, fasting sugar of 130, and HbA1c is 7. So first we'll diagnose this patient. She is subclinical hypothyroidism, mild hyperprolactinemia, and pre-gestational diabetes because the HbA1c is 7.
Sure.
Yeah, please go. So subclinical hypothyroidism, we'll take individually. So we have subclinical hypothyroidism, mild hyperprolactinemia, and pre-gestational diabetes. So with subclinical hypothyroidism, if we see the pregnancy limits, it is 0.1 to 2.5.
No, non-pregnant. She is now non-pregnant.
So, but in pregnancy, it is 0.1 to 2.5. We have 2.5 to, 2.6 to 4, and then above 4. So this patient had a TSH of
5.6.
5.6. So definitely we'll treat her with thyroxine. The middle part where it is between 2.6 to 4, we can get the antibodies done, and then depending upon the antibody status or individual, it's an individual decision, we give her thyroxine replacement. Then we come to the diabetes part. So this is pre-gestational diabetes. So insulin would be the preferred treatment. The HbA1c target for planning pregnancy would be less than 6.5, and with a pre-meal sugar of say around 80 to 110 and a post-meal of less than 155. That is what the guidelines mention. There is a consensus of metformin. So if the patient is already on treatment, metformin can be continued with an addition, or instead insulin can be given. So mild hyperprolactinemia. So now prolactin is a very sensitive hormone because there are a variety of physiological as well as pharmacological factors. So for example, sleep and then stress and breast stimulation, even intercourse in a couple of while can fluctuate the prolactin levels. On top of that, domperidone is a very commonly used drug. We have antidepressants that can fluctuate the prolactin levels. So depending upon the history, the mild hyperprolactinemia, the current consensus in the evidence, it says that it should be repeated. Not a single reading of prolactin should be addressed immediately. So for this patient, definitely requires thyroxine, definitely requires insulin, and prolactin needs to be repeated, would be my...
And what would be the ideal prolactin you would want us before we start?
Ma'am, it should be normal. Because ma'am, what happens is with this mild prolactinemia, there is a sort of lowering down of progesterone without any effect on the menstrual cycles. So this can lead to infertility. So prolactin needs to be normal if this patient is planning pregnancy. That is very clear in the evidence.
So even the guidelines talk the same as you had talked about it. So what are the other endocrine factors? Do we need to evaluate luteal phase deficiency? This is for Dr. Aarti, ma'am.
Apart from the thyroid, diabetes, hyperprolactinemia and polycystic ovaries, it is the luteal phase defect that is the endocrine factor. Then the other hormones that are associated are the increase in the androgens, that is increase in the testosterone, then LH levels. It may be or may not be associated with PCOD. And hormones that are associated with increased maternal age, that are the FSH, then estrogen, inhibin A, and AMH. They should be also should be tested. And other is the hyperhomocystinemia and vitamin D levels.
Comment on luteal phase defects.
Yes, about the luteal phase defect, it causes decrease in the progesterone secretion, and hence, and we know that the progesterone is required for the maintenance of pregnancy, and hence we relate the LPD with the recurrent pregnancy loss. But the consensus says that, and the testing modalities for LPD are the endometrial biopsies and serum progesterone levels in the mid-luteal phase. But the consensus says that these tests should no longer be done, and they are not done now because these tests have a very low sensitivity and specificity. And about the treatment, the progesterone should be given, or it is recommended only in cases of unexplained RPL.
I think even in
And
every PCO,
HCG is also not recommended.
even in PCO, I think there is always luteal phase defect. Should make it mandatory to give in all PCO that you look after.
Yes, ma'am.
So hyperprolactinemia, subclinical thyroid, and blood sugar should be optimized before they embark on their next pregnancy.
So we come to the last case of the discussion today. She is G3A2. First was an MTP for at 10 weeks, and second was at 18 weeks, painless spontaneous labor and the loss. This time she is 12 weeks with a 2.5 centimeter cervix. So my question is for Dr. Indraini, madam. What is the probable cause in this case of loss? How will you manage this patient?
It's very obvious. The probable cause is cervical incompetence. And the reason being maybe iatrogenic because she went for MTP, first 10 weeks MTP. So it's very obvious. It's cervical incompetence.
So there is a role of history-induced cerclage. Because I said that the cervix was 2.5 centimeters. This was normal. So should we go ahead with the cerclage?
Yes, yes. Any cervical length 2.5 or less than 2.5 is an indication for cervical encirclage. So we should go for cervical encirclage in this patient.
So suppose if we had a primary and she is 2.5 centimeter with an internal os closed, and how will you manage her, give her a cerclage or not? She has high tendency of getting into spontaneous preterm labor. But since she is just primary, on clinical finding, though the ultrasound finding were like 2.5 centimeter, but somebody did her PV and clinically she was short cervix. So would you be advising her encirclage, or there are other drug modalities?
Ideally, if we go in for cervical length, 2.5 centimeter is an indication for cervical encirclage. She has definitely got short cervix. Even if she is primary, she is a candidate for spontaneous second trimester abortion because of cervical incompetence.
She's primary, that's what we have a lot of
Yes,
confusion.
she's a primary, but still you can give her an option for cervical encirclage because we don't know at what time she is going to have that incompetence, and she may land in the second trimester abortion.
Is there any role of progesterone in such cases?
Yes, yes. Progesterone is the main hormone of pregnancy, and progesterone has its properties of preventing uterine contractions. So progesterone definitely has got a role, and we give progesterone, either synthetic progesterone or natural progesterone we have, and progesterone definitely plays an important role in.
If we have
Means it is a supportive treatment.
Pure supportive treatment.
Along
yes.
with cervical
Proven also.
encirclage, it will be a supportive treatment. It is not a replacement for cervical encirclage.
And if we have twins, so empirically for the twins, would you advise encirclage?
See, even in case of twins, the studies have been done. No conclusion that for every twin pregnancy you should go for cervical encirclage. Definitely the cervical length 2.5 centimeter or less, or the internal os more than 10 millimeter, or previous history of second trimester abortion. In that case you can go, but it's not a blanket rule that for every twin pregnancy you should go for cervical encirclage. You can manage it on with tocolytics and other progesterone and other treatment also. If there is a good cervical length, it's not a short cervix, then it can be managed.
A brief comment on emergency cerclage.
Emergency cerclage can be done up to 24 weeks. But again, you have to counsel the patient about the outcome.
Chances of,
That should be very clear, because nowadays we are facing main problem is that doctor आपने तो बोल दिया था सब ठीक हो जाएगा, then why she aborted.
She comes back about it.
So it is recommended till 24 weeks, but not after that. So counseling is very important.
As you aptly said, and even our Indian bodies and FOXY recommends for recurrent miscarriages, oral digosterone, 10 milligram BD till 20 weeks, or micronized progesterone. There are multiple trials, systemic analysis, Cochrane, they all are supportive of it. Now, this is a question for Meghna, madam. What are the other anatomical factors causing miscarriages? Are there any guidelines for pregnancy with fibroid uterus?
See, the most common anatomical factor causing miscarriages is a uterine septum, which definitely after correction gives rise to good clinical outcomes and good pregnancy rates. The second can be a unicornuate uterus, where ideally there is no treatment. The only thing is that you should monitor cervical length, because unicornuate uteruses tend to have short cervix as soon as the pregnancy advances. So keep monitoring the cervical length with the transvaginal ultrasound. And as soon as you find that the cervical length is less than 2 or 2.5 centimeters, you can put on a circle arch. This is regarding the anatomical factors. And other variations are also there, like uterine didelphys and other, which you cannot do much about. Only uterine anomaly which can be corrected with positive results is a uterine septum.
And the fibroid?
Yes, definitely. That was the second question, the fibroid. Treatment of fibroid depends upon its location. If it's a subserous fibroid, nothing doing with it. If the patient has no complaints, she has no pain, she has no bleeding. So just for pregnancy's sake, you are not supposed to touch the subserosal fibroid. If it is an intramural fibroid, which is indenting upon the cavity, or it is very big in size and the patient is not able to conceive, then you might plan or you might think removing
resection of it.
Yes, resection of the fibroid, because myomectomy itself has many disadvantages. It is not a surgery which does not come with its baggage. It is a surgery which comes with its baggage. So you have to really think, decide whether you really need to do it, the patient needs it or not. If it's a submucosal fibroid, then I may think that yes, the patient may need it, because submucosal fibroids are very troublesome.
Notorious for.
Yes, they are very notorious. They give rise to menstrual complaints and they give rise to recurrent abortions
RPLs.
also. So the management of fibroid primarily depends upon its location and not the size. So I would consider treatment on the location.
And what are the guidelines? We've already talked about it, but
Yes.
for the patients with uterine anomalies.
Yes, I've already spoken about it.
Yeah,
That
reconstruction.
the correction I will do only for a uterine septum.
Septate,
Others, it does not give any result. Metroplasty and all, these are all outdated.
So, Meghna,
Yes,
we've
ma'am.
spoken about congenital uterine anomalies.
Yes.
What about the acquired ones?
Acquired uterine anomaly maximum I have seen is the synechiase, which needs to be removed definitely.
After that?
Yes. And then after that, the synechia are removed, then the patient has to be put on a good dose of estrogen and progesterone. And when you find on serial ultrasound that the endometrium is showing good triple layer endometrium, then the patient can conceive. So, ma'am, I just want to add one thing. Listening to all the panelists, I just want to say that in the first case, I will not do genetic analysis. I will not do any other test. The patient is a clear-cut case of
obstetric
APLA.
APS.
Whether she comes out positive, whether she doesn't come out positive, it doesn't matter. She has to be started on heparin in the next pregnancy. That takes care of everything. I will not do any test in her. I will not do genetic test in her. Genetic tests don't give any results.
Yeah,
it just adds to your explanation to the patient. It will not give you any positive result as far as the prognosis is concerned.
That's
So in
what
the first
even
case,
Girish sir was also
yes,
stressing
in
on.
the
Let's
first case,
history.
no test, nothing. She's a clear cut of APLA. So just start heparin, aspirin in the next case, and we are done with this.
Done with that.
In other cases, in the case of doctor couple, yes, that is a very difficult case to treat. Since it is a doctor couple, all investigations have been done. So I would go for all the fancy items like LIT and immunological therapy, because I have to tell them something. I have to give them something. Whether it is clinically relevant or not, I am not bothered. In another case in which the endocrine abnormalities are there, definitely we have to treat them and then proceed forward. So
I'll just stop you there, Meghna, because we are running short of time.
Yes.
We won't repeat what has already been spoken
definitely.
about. So I'm sorry to cut you short, but we have to do
I
it.
just want to add one thing. History is the most important thing.
Absolutely.
That's it.
Absolutely.
That takes half of the investigations away from your armamentarium.
Correct.
You cannot go for a battery. That's it. Thank you.
Dr. Soumitra, anything you would like to say on this last case? On uterine anomalies, circlage?
Circlage, yeah. One question was there for the primies, circlage.
Yeah.
I'd like to comment upon that. In primies, usually it's not an indication, firstly, but unless if she's having threatening preterm symptoms,
yeah.
that time only, or if there is a funneling, it goes for a funneling for the review USG. You should do the review USG. and see if the membranes are protruding and funneling is there. Then one can go for an emergency. There you can go for an emergency circle.
In dynamic cervical assessment, if it is like decreasing trend, then
The
even in
priming was
primaries.
only 12 weeks, so we can always monitor. We can do
Yes.
encerclage 16 to 18 weeks. Again, we can
We
reassess.
can
If
review
there
the
is no
USG.
funneling, primaries go well with 2.5 centimeter. In fact, they deliver normally.
And another point in emergency cerclage, this is my personal experience. The patients who have undergone IVF, having multiple pregnancies, triplets and twins also, then they have got a tendency, I don't know why, they usually go for a preterm or they abort. So for these patients, yes, they have got a prophylactic role of prophylactic cerclage, and sometimes we have to do emergency cerclage in those patients also. And of course, some patients who are having a placental problems like placental previa and all, that is mentioned. That's a very long, literatures are very old one now. These are 2 points I wanted to say. Otherwise, histoscopically, we can manage some problems of the submucous, some septum also, or Sanicky also. Histoscopically can be managed.
And madam, sometime going through the books, you have to change your strategies according to the need and according to the patient. One of the patient, my patient who was conceived at Dr. Shikhande madam, she was having twin pregnancy and she came to me at 28 weeks with a 3 centimeter dilatation. So I give her atosiban and extreme Trendelenburg this position. Then I did cervical encerclage and fortunately that patient went till the full term.
Correct. That was very
Anything
fortunate.
can happen.
But
you
again,
should try. You should try. मतलब छोड़ देने से अच्छा कुछ करके देखना
Absolutely,
चाहिए.
absolutely. But with
With
perfect
good counseling, of course. Counseling and consent.
Yeah. I mean, just think every patient can have litigation against you. So counsel that way.
Yeah, on this note, I would like to say some 2 weeks back, sir, even we have delivered it. And we talked to the patient ki by giving it, you can still have a preterm. She did not opt for it. And we continued it without cerclage. She delivered at 34 weeks. Though she did not reach at, and she was primary. On top it saw spontaneous conception, twin gestation. But she, with the bed rest and the Trendelenburg position, as you say, she continued with the dihydrogesterone support. So 34 weeks we delivered her.
See, complications are only always in percentage. I mean, this is the percentage of complications. So, ये भी हो सकता है, वो भी हो सकता है. It is not 100%
So I think
your
it has
to be the choice of patient.
Yeah, yeah.
So
Of cervix.
absolutely.
Rescan. Cervix.
And even madam, position of patient at the time of sonography also matters. I mean, if she is having little this head low position, so you will not get the correct cervical length also. For example, my wife, मुझे वृषाली से जेव्हा सोनोग्राफी सुनील कावराने केलं होतं, he told that अरे don't worry, उसका cervix 3-4 सेंटीमीटर है, and she immediately delivered preterm after 4 hours.
Here I want
So
to say.
ये इस पे I have given up अभी वो सब.
So thank
Here
you
I want
so
to say
much.
one thing only. We should make a habit of doing PV, per vaginal examination, of every patient in first antenatal checkup. So that we automatically come to the length of the cervix.
Clinically.
And immediately, if she complains of mala potat dukte hai, if she is getting pain, we can again do the PV. And if we don't go for ultrasonography, we can immediately will come to know. Second thing, I have been referred with 2 patients who were suggested cerclage. I gave them vaginal progesterone and they went till term. So even vaginal progesterone acts very nicely with uterine relaxant.
So thank you so much, all the panelists. Dr. Sonitra, thank you so much. Let me conclude by saying that RPL accounts for 1 to 2% of all women trying to conceive. As we've heard, etiology is heterogeneous. Definitions were all said by everybody, but couple of things were missed. Was it has to be from the same partner, and they have said up to 20 weeks, and ASRM has said up to 24 weeks. But remember, age is a very important factor. I think older patients start investigating earlier. A few new developments, intrauterine adhesions. After your adhesiolysis, there is a lot of research going on uterine stem cell infusion, bone marrow infusion. There are use of flavonoids called eupetaline, which reduces the flavonoid activity inside, not the flavonoid, sorry, the fibrosis activity, and prevents adhesions. For thin endometrium, PRP, stem cell, and GCSF. Genetic, as Mugdha said, PGTA, non-invasive sequencing, paternal and fetal chromosomal microarray. Again, DNA fragmentation index must be done by all of you who are doing infertility. Infections, COX is very relevant even today. Endocrine, hyperthyroid, PCO diabetes, and please keep the endocrinologist in the loop once your patient conceives. Immune factors, again, very difficult, but we have some hope at the end of that tunnel. Psychological support is very, very important. Lifestyle management has to be emphasized every time you counsel them. And in spite of all these efforts, remember, we are not God. There are still couples who will fail to achieve a pregnancy, and we may have to proceed with surrogacy and adoption. Thank you so much. That was wonderful. Thanks a lot.
Madam, one thing I want to add. If DNA fragmentation index is higher, then straight off patient को donor नहीं बोलना है. Testicular biopsy के से हमें अच्छे sperm मिलते हैं low DNA fragmentation.
Not only that, you treat them properly with good antioxidants.
Yes.
If we give them antioxidants, most of
antioxidants doesn't work many times.
Thanks to NOGS,
Thank you very much,
Varsha.
our dear moderators and organizers, for your opportunity. Thank you very much, ma'am,
Thank you so
for
much.
conducting them.
Thanks to Varsha and Sangeeta. Thank you so much.